Well, first of all, the SPPORT trial, our NRG 0534, was originally published back in 22 by Dr. Alan Pollock. It examined an important question of intensification of therapy in post-surgery biochemically recurrent patients. There were three arms. The first arm, patients were randomized to post-op prostate bed radiation. The second arm included the addition of short-term androgen deprivation of 4 to 6 months. And the third arm further intensified treatment with the addition of pelvic lymph node irradiation. So the original report showed that arms 2 and 3 really had incremental gains, in the primary endpoint, which was freedom from progression. There were decreases in distant metastasis, but metastasis-free survival was not quite statistically significant with an 8-year median follow-up. So shortly thereafter, we examined the Decipher 22 gene classifier, which many folks know has been shown to be highly prognostic for metastasis and localized prostate cancer, not only definitive, but also in the post-operative biochemically recurrent setting. So our hypothesis was simple. Could the genomic classifier GC be independently prognostic in this group of patients from the SPPORT trial? So we prospectively collected prostatectomy tissue specimens from the SPPORT trial and then ran them on the Veracyte Decipher clinical grade whole transcriptome microarray platform. We generated scores, GC scores from 0 to 1. This was a National Clinical Trials Network, or NCTN approved integrated biomarker study from the SPPORT trial with the goal, as I said before, of trying to validate the prognostic ability of the GC for freedom from progression. We also had a number of secondary and exploratory endpoints, which we did not report at GU ASCO. So first of all, we were able to generate about 700 scores from the original 1,700 patients. Fortunately, it was evenly balanced between the three arms, so 215 GC scores in arm 1, 247 in arm 2, and 247 in arm 3. Again, luckily, the arms of these biomarker cohort patients was evenly balanced for key covariates. The important findings are following. First, on multivariate analysis, the GC was found to be prognostic as a continuous variable, but also categorical variable for freedom from progression. There was no significant findings between the GC or genomic classifier and adding short-term androgen deprivation therapy to prostate bed radiation. However, there appeared to be some significant interaction between the genomic classifier as it related to the benefit of adding pelvic lymph node irradiation. Yeah, sure. So as I mentioned previously, there did not appear to be any interaction between the GC score, genomic classifier, and the addition of short-term hormones. However, there did appear to be an interaction, a treatment interaction between the addition of pelvic lymph node irradiation, depending on the GC score. So more specifically with regards to pelvic lymph node irradiation, we noticed that there seemed to be a greater benefit of that treatment intensification in the higher GC scoring patients with a hazard ratio of 0.36 that was statistically significant on interaction p-value analysis of 0.04. Similarly, for metastasis-free survival, there appeared to be potentially a predictive benefit afforded by high GC score when we looked at pelvic lymph node irradiation. In this case, comparing arms 3 versus, so the addition of pelvic lymph node irradiation versus at the control arm of arm 1, which was prostate bed alone, and combining arms 1 and 2 together, which arms 2, as I mentioned previously, was the addition of short-term hormones. So patients with higher Decipher scores or higher GC scores appeared to benefit more from that pelvic lymph node irradiation and the hazard ratio there was 0.6. And again, very near to significant P interaction value of 0.06. We use the standard clinical cutoffs of low, intermediate, and high uh, genomic classifier risk groups, and those are represented in the standard of care test as 0.45 and 0.6. Well, I'd like to remark that this, to our knowledge, represents the first prospective integrated biomarker design validation study that the genomic classifier is independently prognostic in this post-surgery biochemically recurrent population. It's obviously very applicable for risk stratification, given this is a more contemporary cohort than has been examined in the past. Importantly, a few points. The first is low genomic classifier patients were of sufficiently indolent clinical nature, biological aggressiveness that they did not appear to benefit from any treatment intensification. So perhaps prostate bed radiation alone is sufficient in those patients. The second point that is of note is that we observed that approximately half of patients, so about 48% of patients that had low or intermediate GC scores, if you will, they did not sufficiently seem to benefit and thus could be spared the toxicity of pelvic lymph node irradiation. An important biological implication of these findings suggests that lymph node micrometastases may be a sole site of metastasis in these patients, and it can be effectively eradicated with pelvic lymph node irradiation. I think these findings are interesting, but they do require further validation before broad recommendation. And we at the Energy have ongoing randomized trials in this post-op biochemical recurrence setting that is, again, prospectively evaluating and incorporated the Decipher clinical platform to allow us to test not only the genomic classifier, but another set of transcriptomic biomarkers. And those some of those trials include Energy G002 and Energy G006. So we look forward to doing those analyses and providing additional high-level evidence in the future.